For the past 35 years, every day of my life, I've thought about neurons, the real ones, though, not these neurons. And in the 35 years of clinical practice, I'm going to tell you something that may be a little bit upsetting. Your doctor, much of the time, is guessing, and you are gambling. There are very few occasions where a decision about what drug or what treatment to give you are based on evidence-based medicine. And even in the minority of cases where it is, those trials are population trials, and they don't apply to you as an individual. And very often, you have an unusual reaction to a treatment. That's why you have situations such as giving an antidepressant to some people who take it and immediately jump out of a window. Opposite effects. So what can be done about that? Now, you've heard a lot today about brilliant accomplishments. They're early stage, but they're brilliant accomplishments. I'm not going to talk about accomplishments. I'm going to talk about a proposal. I want to be a consumer of this technology. I want to do the clinical trials that haven't been done. And I will do them in an area that's of interest to me, that I've devoted my life to, which is epilepsy. But everything that we say about using machine intelligence, deep learning, to optimize the choice of a treatment for a patient with epilepsy could be immediately transformed into blood pressure, heart disease, cancers, any other disease that you would like to name. This is one way that you could choose a pill. It's the unblinded, single-tailed method if you're a statistician. And I maintain that some of your physicians are not using a method that's any better than that mouse. All of these people are reported at some point in history to have had seizures. Now, what's the difference? Epilepsy is the condition of spontaneously recurrent seizures. So if you have a seizure because you have a concussion in the football game, it's not epilepsy. But if you start having seizures a month later because of that brain injury, then it is epilepsy. I could spend the rest of all of our time on this one slide, but I will move on. Epilepsy is surprisingly common. I'm virtually certain that someone in this room has epilepsy, probably more than one. It affects more than 1% of people in the world. And if you live to be 75 years old, chances are 10% that you'll have a seizure being an electrical storm in the brain. About 2/3 of people with epilepsy can be controlled with medications after a period of trial and error, but 1/3 can't. And because epilepsy is so prevalent, that number is greater than all brain tumors, all multiple sclerosis, all muscular dystrophy, all Lou Gehrig disease. These are the treatments for epilepsy: medicine, brain surgery, ketogenic diet, neurostimulation, which is my personal area of research, biofeedback, and especially here in California, a variety of alternative therapies. But medicines are by far the mainstay. Here's a timeline of all of the seizure medicines that have been used, starting with bromides in the 1850s, which were done at a time when epilepsy was thought to be a type of insanity, and that insanity resulted from sexual tension and masturbation. They didn't have advanced medicine. Now, of course, we know that masturbation does not cause epilepsy, it causes blindness, but they didn't know that back then. So they gave a treatment of saltpeter and bromides, basically gunpowder. And it turned out that that was effective for epilepsy, but very toxic. And so we move up through the chain, and we now have 26 epilepsy medicines to choose from. So when you come into my office, having just had a couple of seizures, how do I decide what you're going to take? Well, I use clinical judgment. In my view, the definition of clinical judgment is having made the same mistake enough times that you automatically don't make it again. So when you get to be in the business for 35 years, you probably are a little bit better at picking a medicine based on these factors. But you're still going to be wrong, and you're going to do trial and error most of the time. So this is the better way. Do you see a cat? A convolutional neural net can. And then we come to the nature of the slides that you've seen since the start of the conference, except can they be applied to a medical condition? Can we put in information, all the omic data that we have, all the lab data, coupled with some stereotyped forms that patients may fill out to give information on their disease, their seizure types, their seizure frequency, the side effects, and so on. Many other inputs to go through the net to come up with an optimal anti-epileptic drug. It's rather an article of faith at this point to say that this approach would work, but I very much think it would, because I can think of particular cases. You can have certain liver enzymes we know about that will make it very hard for you to metabolize phenytoin, dilantin, and you'll get toxic on it very easily. You can have certain antigens on your cells, HLA antigens, that will make carbamazepine a poison for you if you're from Asia. It'll be likely that you'll have a blistering Stevens-Johnson skin rash. These are just two things that we know about. How many million do we not know about, and how do we use all the information to pull it together? This is the way. We collect this information. We develop a cohort of patients. We show a methodology that can work to recruit patients, to track their seizures and their side effects, and then to use some of the models that you have to predict what would be the best medicine to choose, most likely to reduce the seizures, and which medicines would be least likely to produce side effects. Now, what's the problem with this plan? The problem is it would take, you guys in the front row tell me, 10,000, 50,000 patients. So you have to be able to develop the model and to block out a clinical trial, which is something that I've done many times in my life, but never one like this, using just a miniature sample, which will not bring to bear the full power of machine learning. And from there, you then need to take it mass market. You need to take it advertising to the world. So you get your tens of thousands of sets of data. And then after you've gotten that, you then need to validate it by prospectively showing that it works on another cohort of patients. I'm almost a little old to start this, because this is like a lifetime project, not just an experiment, but interesting enough that I'm paying attention to it. So the proposal, and it is just a proposal, which I make to the people in the front row, that we do a test case of seeing if we can apply machine intelligence to predicting a best drug for people with epilepsy, and get beyond the stage of guesswork.